for the practicality of being on the sidelines. So that's a good thing. All right. Everybody see my screen okay? You good? Sound good? All right, good deal. We will start rolling. This is a little bit of a longer talk because it's covering a lot of material. If anybody has any questions, just literally interrupt me. It's totally fine. We will roll through a whole bunch of craniofacial injuries. So we're going to talk a little bit about the sideline approach to handling the injuries. We'll talk about eye, nose, ear, dental, and jaw stuff. So it's kind of the whole gamut of everything with the exception of concussion stuff, which you guys will get plenty of. So sideline evaluation, you're going to really start thinking about your basics. So first and foremost, whenever you have a head and neck injury, you're thinking ABCDs first, and then really making sure C-spine is okay and ruling out any intracranial injury before you're dealing with a lot of the issues that affect the face. The only exceptions, obviously, if you have significant bleeding, you need to control bleeding in order to attempt to maintain that airway in some circumstances. So that's really your basic thing, your basic approach. What I really try and get people to do is always remember to inspect people in two planes. And this seems like something we do all the time for basic joint stuff, but you don't necessarily think about it for face, right? You're like literally staring the person in the face and you're looking at them kind of anterior to posterior, but you can't really tell if there's anything that is potentially more sunken in or more swollen at times. And so laying somebody down and then looking at them from the head of the table is really beneficial. And sometimes when you're on the sidelines, it's kind of a pain in the butt because we don't always have a table to put somebody on, but I've literally laid people down on the turf before, and then you got to get down to head level with them and look at them to make sure that you're not missing anything. You really want to look for any evidence of asymmetry before you see that onset of swelling, because it doesn't always come within seconds. And then you're looking for any bruising and bleeding. That's really your basic visual inspection when you're approaching people with face injuries. And then you're going to start palpating. So you're looking for pain, obviously, but also any instability between bones or crepitus. You're going to do a really good neuro exam looking at cranial nerves, especially around the eye, looking at extraocular eye movements. When you're doing your extraocular eye movement exam, you're obviously looking to make sure you have symmetric movement, but you're also making sure that the athlete's not reporting any double vision or any significant visual changes. So it's important just to ask them also to report that, because sometimes they'll have issues and not know that it's important to report. And then sensation around the orbit's important also, just because of potential nerve entrapments. So we're going to roll through a whole bunch of different injuries, and we'll kind of talk about common signs and symptoms and what to look for. So this showed up on my PEDS board. So this is a skull fracture. Whenever there's blunt trauma, obviously in most of our athletes, this is going to be in a sport without a helmet, but can occur in helmeted individuals. We see this a fair amount in clinic because the PEDS trauma service pretty much sends over anybody who injures their head and gets admitted and follow up to the concussion clinic. So we definitely get skull fracture cases within our concussion clinics. You're obviously going to ask them about where their pain is, but then other signs and symptoms, you're going to look for any significant hearing changes, dizziness. I carry a portable ophthalmoscope, so I look for any blood within the posterior to the TM. So you're looking for that hemotympanum sign. If you see it, it's obvious. It is not something you can miss if you look. And then two classic signs. The one pictured is a battle sign where you have that bruising behind the ear, but then also a raccoon sign is like the double black eyes. So that shows up on PEDS boards as the double black eyes for raccoon eyes looking for skull fracture. And I think I had a battle sign on my CAQ, but it's been so long, I can't remember now. And then another important thing to look for is any clear otorrhea or rhinorrhea. So any clear fluid coming out of the nose or the ears is highly concerning for a possible CSF leak from that nose. And then if you're getting it from the ear, you're looking for blown TM and potentially having skull fracture associated with that. So obviously the main thing, if you see any of those signs or symptoms, or if you have concerning evaluation from a neuro perspective, is really getting that emergent head CT. So these people, if you have anything on the sidelines, you are transporting by EMS. This is not a parent drives a kid to the hospital kind of move. You're looking for any indication for surgery, which would be a depressed fracture. In most cases, neurosurgeon is consulting on these kids, and return to play, depending on where you break and how bad the break is. For a non-depressed fracture that doesn't require surgery, the bulk of the time neurosurgeon holds these kids out for a minimum of 3 months. So when we see them in concussion clinic, it's easy for us because we know that it's in all likelihood going to take longer to heal in the broken bone than to be resolved from the concussion and go back to play. So we approach them a little bit different in clinic, but from a sideline perspective, it's all about just get them to the hospital and get them there via EMS. Any questions about that one? All right, let's talk about eye injuries. I saw a nasty one on Monday when Tyler was with me. So eye injuries, lots and lots of eye injuries that are sport related each year. They estimate 40,000 per year. There has been an increase in use of protective eye equipment, particularly in lacrosse and field hockey on the women's side. So back when I started doing this, neither of those sports wore eye cages. We've also seen an increase in facial protection in softball, with a lot of pitchers and lots of infielders starting to wear face masks for protection. And the softball face masks go lower than just eye protection, but you get eye protection as well as nose and face protection. So there's been definitely some increase in protective equipment, but we still see eye injuries in lots of sports. Even in football, because most people aren't wearing a shield, they have still an open face mask. I see a fair number of injuries from getting poked by fingers. We certainly see it a lot in basketball, and then quite a bit in other sports like soccer and anything really with eye contact. So examining anybody on the sideline for an eye injury can sometimes be tricky. We don't all carry around visual acuity cards. When I was a fellow, I actually carried one in my bag. I have no idea where it lives now, but some athletic trainers will carry a visual acuity card so you can test somebody and make sure their acuity is okay. And then when you're on the sidelines and you've got a nice bright sunny day like today is, doing a pupillary exam can be difficult. So sometimes you have to move these people into a training room setting so that you can get appropriate lighting to assess them. Most important thing is just assessing that pupillar constriction. And then some people, don't know, but about 10% of people have anisocoria. So at baseline, 10% of people have asymmetry between their pupils. So I'll often ask, normally are your pupils the same size? And some people will be like, oh no, my right one's always bigger. Okay, well, that's important to know. And I've occasionally seen like a concussion kid in clinic, and you go to assess them and you tell the parent you're a little worried because they have an acute head injury, they're 24 hours out, and all of a sudden one pupil looks bigger than the other. And the parent's like, that's the way they always are. So that's like an important baseline question to know. But normally what you're doing is a basic pupillary exam, and then you do a swinging test where you're really looking for any evidence of an optic nerve or potentially brain injury. So when you flash the light into the left eye, you expect pupillary constriction. And when you switch to the right eye, you should still get that pupillary constriction. And you're really making sure the other pupil is constricting at the same time simultaneously. If you're getting anybody who's not constricting appropriately and you get more of a dilation, then you're going to be more worried about something, and you really got to get them checked out by ophtho. If you have no constriction, you're worried more about temporal lobe injury or potentially cranial nerve 3. So for me, I'm a simple person. I just look and make sure pupils are constricting. They constrict simultaneously. Everything looks symmetric when you swing the flashlight back and forth. Most of us don't carry a flashlight on the sidelines, but most phones have a light on them. So I tend to use my phone light. And then you're really doing a basic exam. Extraocular eye mints are super important. Like I mentioned before, you want to look for Any double vision reports from the patient, make sure people aren't getting any significant dizziness or anything that alerts you to potentially having a concussion. You're going to palpate that orbit all the way around and check for facial sensation. You can have a nerve entrapment that leads to numbness around the eye if you have an orbital fracture with a nerve entrapment. A lot of the athletic trainers will carry fluorescein. So if people have a lot of eye pain and you're worried more about having a corneal abrasion, you can fluorescein them and then use a blue light to look and see whether or not they have an injury to the eye. And then certainly a fundoscopic exam can be very beneficial. So I'm old and I'm from Detroit and I grew up a hockey fan. So probably you guys are all too young to know who this is because he played hockey before most of you were born. This is Steve Yzerman. He played for the Red Wings for a long time. A pretty nasty eye injury at one point. We're going to kind of roll through the different common eye injuries that you can see. I have, I think, officially seen all of these but a lens dislocation at this point. So we had a kid with a globe rupture in this past week after an ATV accident. So I've now officially seen all of them except for that lens dislocation. So at some point in time, you'll see them all. Corneal abrasions most common, and probably many of you have had this happen at some point in your life. It's incredibly painful. In the sports world, it's usually a finger getting into the eye, but I've also seen it from the rubber pellets from the turf, or some of our turf is a sand fill, and sometimes if you get a decent piece of turf in the eye and it gets moved in the eye, you can get an abrasion from that. Usually the rubber turf usually just causes more of a foreign body sensation, but I usually check them for a corneal abrasion if I fish something out of the eye. And obviously it's more common in sports with no eyewear, but also people who wear contacts can get abrasions from their contact in. It presents with acute pain, blurry vision, a sensation that something's in the eye. So you need to do a really good, thorough exam to make sure there is no foreign body. They're going to tear a lot. They're going to hurt when their eyes open. It just feels awful. It's one of the most common eye injuries that people present to the ER for. You want to fluorescein these people and look, and if you rule out a foreign body, but you see a corneal abrasion, you want to send them home with a topical antibiotic. You do not need to patch them, but they do need to keep their contact lens out. And you want to hold off on return to play until they're healed. Foreign body in the eye, like I mentioned, that sports turf is probably the most common thing we see now. But like a lot of people will get kicked up from the road if they're on their bike and not wearing eye protection. I've certainly had that happen before. Baseball, softball, sliding, and getting the stuff from the ground. A lot of times it's either grass or dirt in the eye, but some of the baseball fields around here are turf. And then again, you get that foreign body sensation. You can see that corneal abrasion sometimes. And then the most important thing is really making sure if they have that foreign body sensation, but you don't get anything visually that you can see, is making sure you're turning those eyelids back. So some people will roll the eyelids like using a Q-tip just to get a good look under the eyelid and make sure you're moving that eye around. If you see a foreign body, the best thing to do is try and sterilely irrigate it to get it out. Some people use like a moistened swab to try and touch it and get it out. You obviously never want to put a needle near the eye. And again, you want to treat with a topical antibiotic ointment. If there's any evidence of a corneal abrasion, or if they have significant discomfort after you fish it out and you're convinced you've got everything fished out, people can't go back into play immediately unless they have a corneal abrasion and they're uncomfortable and they can't keep that eye open in order to protect themselves on the field. Eye bruising, we certainly see this quite a bit, usually direct blow. Again, you're going to really be making sure you're spending time ruling out any orbital fracture. So in soccer, head to head, when people are going up in the air, you'll see elbow to face a lot of times in basketball and soccer. And these are pretty obvious. You're going to just make sure you're ruling out concussion, basilar skull fracture, any orbital fracture. You're going to watch them for development of any signs and symptoms of concussion. Kids can develop concussion signs and symptoms up to about 48 hours later. If somebody takes a pretty significant face blow, you want to make sure you're giving them good anticipatory guidance. The main issue about sending him back to play has to be able to do with any visual deficit. So if you start swelling so much that you can't see well out of the eye in all directions and move that eyeball comfortably so that you can move on the field appropriately, you want to probably hold them out. And certainly if you have any concern because it was a significant blow about concussion, you're going to hold them out. Subconjunctival hemorrhage freaks a lot of people out, but really isn't a big deal in the grand scheme of things. So repetitive Valsalva maneuvers will cause this in athletes. Occasionally a direct finger to the eye will cause this in athletes. That happened to LeBron in the NBA playoffs a couple years ago. Athletes with hypertension will get it, but a lot of times we'll see it post weight room. You get that visible blood, and certainly post illness. So if you have a kid who's been vomiting a lot, you'll see it. But these people have absolutely a normal ophthalmic exam with the exception of the visible blood. So they've got nice full motion, normal pupillary movement, really no pain. The biggest thing is cosmetic, and you have to tell people like this just takes a while to resorb. This is not going to resorb in 3 to 4 days. This is going to take weeks to resorb. You can see it kind of turn a little bit more brownish colored. Don't let it bother you. And it's mostly just good anticipatory guidance. People can go back to play as soon as they're comfortable going back to play, as long as high blood pressure and recurrent vomiting is not an issue. Hyphema, this is not a common injury. I've had it happen on the football field. I had it happen, I think, the first college game I ever covered. I had cleared a kid and done his sports physical at the college, showed up, day one football coverage, kickoff his freshman year. He runs down the field and somebody pokes him in the eye. And he comes off the field and starts immediately complaining of vision issues. We take him into the athletic training room, and I get out my ophthalmoscope. And by the time I get around my ophthalmoscope, he starts complaining of losing his visual field from the bottom up. So anything from bottom up, you worry about hyphema. And sure enough, you look and he has layered blood in his anterior chamber. And I was like, wow, that's impressive. And then the kid disclosed to me he had a bleeding disorder, which was an unknown name. It had never been identified, but he normally walks around with platelets around 6 to 10,000, and he never disclosed it on his physical exam at the time of his PPE. And so I had cleared a kid to play college football, and he had platelets of 6,000, which is probably not in his best interest. So sure enough, he gets poked in the eye on play one, gets a hyphema. These you need to transport to the hospital immediately. You transport them sitting upright. You have them go in an ambulance. They obviously should not drive themselves because they're losing their visual field and they're going to be very panicky. And then the most important thing you can do is call ahead to the ER and get ophtho in there right away. So ophtho, a lot of times after hours, is not sitting in the hospital. They're often sitting at home. And so they need to be notified somebody with a hyphema is coming in. So my athlete played one play of college football and was never allowed to go back because he had platelets of 6,000. Normally, you can send somebody back after a hyphema once they get their vision back and they have normal pressures and there's no concern. So if there's no underlying bleeding disorder, it's not a contraindication to return. Globe rupture is incredibly rare. So this is almost always direct trauma to the eye. This is a pretty nasty one. The one we saw in clinic this past week was not as nasty as this. She actually was on an ATV unhelmeted, which is not a great idea, especially her, because she had a history of AVM with an intracranial bleed that already required brain surgery when she was younger. So I definitely don't recommend you ride an ATV unhelmeted, but something happened where she was riding and she ended up either striking her face against the handlebars or a tree branch took her out. The family has no idea, but she had a direct blow to the face and she lost vision in that eye. So she had significant visual changes in conjunction with multiple other injuries. So whenever you see an eyeball not looking normal, it's pretty easy call to have ophtho. evaluate the kid. And again, this is an ER transport with a call ahead for optho to come in. Whenever you see it, it's an automatic CT scan because it's a sign of significant trauma. There's a good chance of having a posterior orbital fracture that you can't see or palpate on exam. You want to make sure that you transport these people with their athlete upright. You want a protective eye shield on, and then they're going to go to the OR. So they obviously need to be NPO, but they have a very good chance of losing their eyeball. In which case, even if they don't lose their eye, but if they lose significant vision, then you have to follow monocular athlete guidelines to return to play. And depending on the sport, you may not be allowed to go back to play. Orbital fractures are fairly common. We see this more in assault cases than sports, but I think we've all seen one at some point. Basketball and soccer are probably the most common because the high level of contact and being unprotected. The rim tends to fracture with direct trauma, but the wall tends to fracture when you get a direct blow to the eye itself. And the eye can then essentially blow out the back of the orbit. And again, you can't palpate that area. So whenever you have significant trauma directly to the globe of the eye, you're going to CT scan and make sure there's no posterior wall injury. The maxilla is the most common bone to break, and that one's pretty easily palpable. So when you're examining these kids, I always recommend, this is really a good example of why you lay somebody down and you look at them either from the head of the bed or the foot of the bed, because if you blow out that back of the orbit, you're going to get kind of a sunken eye appearance like this patient's left eye, which is on the right side of the screen. So you get a depressed eye, which they call enophthalmos. If you have enophthalmos, it's a concern for posterior wall fracture. But anybody who reports eye pain, and the most specific sign is that double vision is a really good indicator with a direct blow of potentially having entrapment of an eye muscle that's preventing full motion. And so when you entrap that muscle, if you don't have full eye motion and your eyes aren't tracking symmetrically, you're going to get double vision. And then certainly assessing for cheek numbness for any sort of nerve entrapment is important. So a really basic exam can give you a lot of information. So just inspection, palpation, looking at the pupil with the flashlight, doing extraocular eye movements, you get a ton of info. You don't have to have a portable ophthalmoscope to make a lot of these diagnoses. And then scrolling through, obviously, again, it's an emergent evaluation. You're sending by EMS. I usually send them upright because they've had a direct blow to the head. And you're calling ahead to let the ER know what you're thinking, but CT scans indicated because plain films have a very high false negative rate. I also recommend telling these athletes, like, don't blow your nose because of the risk of orbital emphysema. So if you're blowing your nose and you're valsalving, you can have a significant issue with orbital emphysema if you've got a fracture. So the majority of these fractures don't need surgery, but anything that's a large fracture or anything that causes muscle or nerve entrapment or enophthalmos, where there's a posterior wall fracture or a depressed orbital fracture, those people are almost always going to the OR right away. So making these people NPO is also important. Return to play from a non-depressed fracture that doesn't need surgery. You're looking for them to start normal training up kind of around the 3-week to month mark, as long as they're at the point of having no significant pain, no double vision, normal vision. I always have oral maxillofacial clear these kids first. Full return to sports, 6 weeks is the earliest, and a lot of times we're sending them back with a faceplate for protection. Or at least depending on where the fracture is, if it's an orbital wall fracture posteriorly, then you're doing eye protection. So if anybody has permanent vision loss, that sometimes affects your ability to clear them to return to play. Anybody who has persistent double vision cannot go back to play in most cases because it can be a risk for other injuries. Lens dislocation, I have not seen this yet. I don't know if anybody else has, but it's a blunt trauma issue. It's much more common in people who have Marfan's or Ehlers-Danlos. You can get a subluxation or dislocation of the lens. These are people who are totally pain-free but have trauma and then all of a sudden have complete vision loss in an eye. So if anybody is on the field and reports usually one-sided complete vision loss, you're going to be worried about this. Again, you're going to remove them to play, get them to the ED as fast as possible, and have them stay upright. In most cases, they'll get looked at from a genetic perspective too, if they have a lens dislocation, just to make sure they don't have any underlying genetic issues. So you can have an aqueous drainage blocked with the lens dislocation, so you'll see pressure increases, but these people all need a dilated eye exam, so you get opto involved quick. And then retinal detachment, I've seen probably once. It was a direct trauma issue from an elbow in basketball. I saw it way back in fellowship. So these people take a direct blow, and then they will have abrupt onset of floaters, and oftentimes they'll have a flashing light phenomenon. So anybody who has trouble with vision loss that is more peripheral or more curtain-like, you worry about retinal detachment. So hyphema is vision loss from the floor up. Retinal detachment is vision loss from the ceiling down, or peripheral in. So they tend to present in different ways. In either case, if you don't know what's going on, you're obviously sending them to the ER if they have significant vision issues. It's one of those things that opto can figure out for you. So if you have a retinal detachment, most of the times the retinal specialist is getting involved and they're getting surgery to get it remedied. So that is fast and furious eye stuff. Anybody with questions about eye stuff? Feel free to holler. Plowing through. All right, good deal. Nose stuff. So nosebleeds are obviously really common. The majority of them are not that significant, but they can mask a more serious injury. So you want to make sure that you're asking questions about obviously concussion symptoms, but you're looking for any significant trauma that's going to make you worry more about potentially a maxillary fracture, anything beyond just a standard nosebleed. So dry weather, allergic rhinitis, chronic sinusitis, or lots of nasal steroids set people up for recurrent nosebleeds. Anybody with poor face protection. So again, these are your basketball, soccer kids taking direct blows. I have seen some pretty ugly direct blows in baseball this year with kids sliding and getting tagged out. So, you know, other sports it can happen in collision wise, but more commonly kind of that. You know, we don't have many rugby players, but rugby, basketball, soccer, that kind of stuff. Anteriorly, one of the things that they like to ask is like, where do people get their nosebleeds from? So it's Kieselbach's plexus, which sits more anteriorly, which is right here, kind of that watershed area. Oh, you guys probably, I don't know if you can see my pointer. I always forget. Can you guys see my pointer?
Yes.
Yeah, okay, cool. Right up in Kieselbach's area, but then posteriorly, it's sphenopalatine. Where you're going to bleed from. And if you bleed posterior, it's an artery. So those do not like to stop bleeding. So if it's more posterior bleeding, a lot of times you have to actually send them to the ER to get them cauterized. They're going to be swallowing a lot of blood, even if they're sitting upright, and they're going to kind of just feel like they're choking on it kind of thing. But also if you have a portable ophthalmoscope and you look and you don't see the area anterior, or if you're using nasal tampons and the bleeding is just not stopping, you get more suspicious for sphenopalatine, and sometimes they need send in. So those posterior bleeds tend to be more severe. They may start coughing or vomiting up blood because they're swallowing a lot. But you always want to try and visualize the source where it's coming from. The other thing you can do is try and find piece of paper towel and just dab their nose with it and make sure that it's just all blood. If they have a significant head injury and you dab it and there is a layer of clear fluid around the blood, that's a positive ring test, and you're going to be worried more about a CSF leak in conjunction with the nosebleed. So it's never a bad idea just to dab that paper towel underneath there if you have access. If it's more of just a standard nosebleed, direct pressure, nasal packing, most athletic trainers carry nasal tampons right on the sidelines. A lot of them will do a topical nasal decongestant. So you may do like a spray to Afrin in each nose and then pack them. But like I said, if it's a posterior bleed, then you're sending them to the ER. If they have an anterior bleed and you can get the bleeding to stop in a reasonable amount of time, and you can get blood cleaned off of them, a lot of times they can go back to play. Just depends on whether or not you've got concern for anything more serious going on or not. So nasal fracture wise, they're very common. The proximal half of the nose is a bony location where cartilage is more distal and provides shape. Most of these, again, direct trauma, you're getting nosebleeds with them in most cases. You're going to rule out other issues at the same time. If you look at them again, this is a great reason to lay somebody down to look for any sort of significant deviation. When you're thinking about sending to the ER, if anybody has any significant deviation and you are not reducing it on the sidelines, which most of us don't do, it's not a bad idea to send them to the ER right away. And the main reason is access to ENT. If somebody just tries to get into ENT from home, it is near impossible. If somebody has a displaced nasal fracture, you're never wrong sending them to the ER so that ENT can realign them in the ER right away and then split them right away. If it's a significant fracture that ends up having to go to the OR, they're going to be connected with ENT already, and it's just way easier to get them in. So I dealt with this in my house, I don't know, probably about 10 years ago now. My partner took an entire forearm to the face in basketball and came home with a nose that was crooked and bleeding like crazy and had a laceration. So I living room treated her. And then once I stitched her up and got her bleeding control, because it was late at night and we had small kids, I was like, yeah, we're not going to the ER. The next day, I could not for the life of me get her into ENT. And so I had to go in through backdoor methods to get her in. And I could not get her in through scheduling. I couldn't get her in through contacting their office, even though they knew that I was a physician in the system. So I finally had to just direct call an ENT doc and get her in. So it is near impossible to get into ENT acutely. So if you have somebody you think is going to need to see ENT and they have direct trauma, I just send them to the ER because they'll get connected way faster in most cases. If there's no significant bleeding, there's no malalignment, and they're just tender on the nose, then you're going to do a good exam, and you want to look from the bottom up because you want to check them for a septal hematoma, which is what's in this picture here. So you can see that big bulge in that left nostril. If you get a septal hematoma, they're much more likely to develop a saddle deformity. So it's a red flag that deformity could occur in the future. So they're going to have a completely occluded nostril on one side. It does sometimes take a little bit of time to develop. So anybody with nasal trauma, when I see them in clinic, I'm always evaluating for this also, but you can get it pretty quick in some cases. The other thing to think about is looking for other issues. So malocclusion of teeth, CSF drainage, all those things. So, but septal hematoma, again, is another reason to refer them to the ER. If somebody takes a direct blow to the nose, they just have bleeding, no septal hematoma, nothing looks crooked, they're breathing okay, and you think it's a non-displaced fracture, there's really no reason to go to the ER. The reality is we don't do much about non-displaced fractures. So this is a good picture of what a saddle deformity looks like. So septal hematoma can lead to that as a result of blood getting trapped between the cartilage and the supporting perichondrium. There is also an infection risk. So if you see these, you're calling ENT to let them know somebody's coming in because they're going to need to drain them and pack them. So if you see a septal hematoma, just make sure you're giving ENT a heads up. So there's a high false positive rate of fractures on plain films of the nose. I really never image these kids unless I have concern for something more significant, either orbital or periorbital on the maxilla. Because you're just not going to do anything different. So I'll have parents bring their kids in and be like, well, I know they broke their nose, I want an x-ray. Well, there's no deviated septum. You look straight on exam. There's no septal hematoma. Your nose is tender, swollen, and bruised. Guess what? We just treat it like it's broken. If it's non-displaced, we do nothing. If it is displaced, immediate reduction is what works best. If they're not immediately reduced, you really only have about a week window before they have to be reduced. So if you get a kid in a training room who is already a couple days out and they need to be reduced because their nose is crooked, then you're usually having to get that on-call ENT involved because, like I said, accessing them just by calling is impossible. Return to play in season for non-displaced fracture is pretty quick. ENT lets these kids go back at that 1 week mark as long as they have a face shield. So you can buy decent face shields on Amazon for a cheap amount of money. People absolutely hate playing in face shields, but I do not let anybody go back without one. So I usually write a note like mandatory must play in face shield. If no face shield, can't play. So that's a good one for nose. Any questions about nasal stuff at all?
If you so if you have somebody who has a like suspected fracture and you're trying to call ENT and like training room, do you just call the transfer center to try to get a hold of them?
Yeah. So if you're just calling like an on-call person, like if you're just in training room and you wanted to get this kid set up as soon as possible, I would just call like the on-call person. Anybody who you're sending to the ER, you call the transfer center head. Yeah. And then usually they connect you right to they'll take the basic patient info, but then they'll connect you directly to the ER attending. And then you tell them like, look, I've got concern for X and, optho needs called in or ENT needs called in, and you let them know how far out the kid is. But yeah, when you need those subspecialists in, I always call ahead because optho and ENT are often, sitting at Starbucks after hours and they're not in the ER. So, they need notified, they need to get in. So it's helpful. We had a kid a couple years ago at one of the outlying high schools who like had a pretty significant head injury, and the kid started to like act super weird on the sidelines, and they like threw him into the ambulance, and Hawken is closest to Hillcrest. And I'm pretty sure it was Sarah who then called up, like somebody called up to Hillcrest and said like, this kid had a head injury. Like, I really think like you need to get them in ASAP. Like they are not acting right. And literally between like Hawken and Hillcrest, which is about a 4-minute drive up the hill, the ER was able to coordinate getting the kid in for like a CAT scan super fast. And he had like a significant head bleed with a temporal bone fracture, and they were able to get neurosurgery quick. But it was literally probably having that phone call ahead, which cued the ER to have like a high level of suspicion. So, I tell people all the time, you are never wrong just picking up the phone and calling. You're way better off giving them notice.
And you said that they wear the face shield for the rest of the season. Is there like a timeline that, like if the season's about to end, they're about to start another sport?
Yeah, so I mean, normally, for nasal fracture, I'd put them in for 4 to 6 weeks, depending what they're going back to, right? Like a high risk sport like basketball, soccer, I'd probably give them like a solid 6 weeks. It's really until they don't have significant tenderness along that area. So if their tenderness is gone at that 4-week mark, I'd let them go back. So, and it depends, like if they're switching over and they're going from basketball to track, like who cares? It's track. They're not going to be taking a load of space. So, I wouldn't make them wear it for that, but anything contact, like I'd have them wear it for. All right, we will keep rolling along. So ear, this is like your main wrestler's injury. Cauliflower ear is when you get a collection of blood between the cartilage and the perichondrium. It comes usually from a shearing force or direct blow. So this is the kid's head getting tacked onto the mat and then sheared on the mat, but direct blows can lead to it. The main reason people get them in wrestling is because they're not wearing their headgear. So this is a practice injury in most cases. Once it happens, you're much more likely to have it happen again. Having one in the past is a risk factor for a future one. The bummer is if you get it and you don't take care of it, you get left with this cosmetic deformity of having ears that look like this. So you usually will see, parents in clinic bringing their wrestling kids in, and you're like, oh, Dad, I can tell you wrestled in the past. It's kind of the landmark of a person who wrestled. You get that deformed pinna. It's a little painful. It's mostly a cosmetic issue. The main thing is aspiration. So you can aspirate these. when they're fluctuant, which gives you about 24, maybe 48 hours. Anything past that window, you're going to start getting clotting of the blood within that space, and you're not going to be able to evacuate it. We don't often evacuate these. A lot of times ENT handles these at our hospital. And again, getting somebody in can be a pain in the butt, and getting them in quickly can be challenging. But if they have significant accumulation, the best thing to do is call the on-call person and then see how you can get them into clinic to get them drained. We can drain them. Like, I've drained these before. The big issue is once you drain them, they have a very high chance of reoccurring unless you can pack them. So you have to be able to pack them and then put on a compression dressing so that they don't reaccumulate. So what ENT tends to do is they tend to use a blade. A lot of times they'll do compression dressing like this, where they will sew on kind of that compressed cotton, or they'll sew in a button. And if they do that, they're much less likely to reaccumulate. And we just don't have access to do all these things in clinic. Where I did fellowship, we had a dental amalgam. So it's the same paste that gets used if you're having dental molds taken. And we would literally mix the dental amalgam and then drain these kids and then pack them in with the dental amalgam and then give them a beautiful head wrap, like they just walked off like the, World War I military field. But that's the best you can do. The issue with just doing a packing is that kids can remove it, and most kids are non-compliant and they'll take it out right away, versus if ENT stitches padding in or a button in there, they can't take it out. You're going to have better compliance. So you really have to keep the dressing intact for a full week in order to decrease the chance of it reaccumulating, which means you're telling a kid they can't shower or play sports for a week, and they all hate this. And so if you just pack them, they're going to take it off and they're going to reaccumulate. If ENT can get them taken care of by stitching something in, then a lot of times within a week, they're good to go back to that contact, and they can go back to non-contact sooner. It's all about restricting that contact. Dental injuries are super common. We see them across lots and lots of sports. The Dental Association really recommends having a mouth guard in for all contact and collision sports. There's multiple kinds of mouth guards. There's just a stock mouth guard, which is what a lot of people wear. There's a boil and bite, which is what you can find just even up at Dick's Sporting Goods, where you literally put this in boiling water for like 60 seconds, pull it out, let it cool, pop it into your mouth, bite down, run it under cold water. You get a pretty decent dental impression. It's really not a bad way to go. For kids who have braces on, I usually recommend more of a custom molded piece. The orthodontist can make them for people. And that custom molded piece does a better job when you have braces on. So I tend to really recommend anybody with braces plays sports in mouth guard. I've seen some pretty nasty gum and lip injuries from braces and poor dental stuff. So there's several different tooth injuries that can happen. Subluxation is when you just get a loose tooth. Intrusion is when the tooth gets driven into the socket. So the kid who I saw in the ATV accident the other day actually had 2 dental fractures and an intrusion. There's an extrusion where you dislocate, but you're not completely out and you have neurovascular damage. And then an avulsion is when it pops completely out of socket. The only true emergency, so in isolation for a dental injury, the only thing you absolutely have to send somebody to the ER for out of this list would be an avulsion. So if the tooth comes out, that is not a wait and see the dentist issue unless it is a baby tooth. Okay, so an intrusion is pretty obvious. You get asymmetry from direct blow. It's a forceful closure of the teeth or object striking the teeth. It's due to having that poor mouth wear. Most people get a sensation of malalignment. There's an obvious shortened tooth. And then it's usually an urgent dental evaluation. It's like, okay, let's get you in to see your dentist within the next couple of days. A lot of times they'll splint the tooth and then they'll figure out what to do from there. But again, not an ER trip in isolation. An avulsion is an ER trip in isolation. So if you have a complete dislocation and you have an empty socket, then that is a trip to the ER, especially if you have the tooth in hand So the goal is to get that adult tooth reimplanted as soon as possible. If you have a baby tooth that came out, whatever, forget about it, doesn't matter. If you cannot find the tooth, there's concern for it getting aspirated. So a lot of times we recommend sending somebody for an x-ray just to make sure it's not sitting in their airway as opposed to their stomach. If you do find the tooth, the most important thing to do is implant it as soon as humanly possible. You want to hold the tooth at the crown. You never, ever, ever want to touch the bottom of the tooth, and you want to rinse it very gently. Most of the time we say just grab some saline or sterile water and just literally pour it over the tooth. And then you want to identify which the front portion of the tooth is, make sure you're not putting it in backwards. And then you want to literally put it in the socket with minimal pressure. You don't want to shove this thing in there hard. You do not want to do this if there's any concern for mental status changes in the patient. Okay. So if you think the patient is kind of out of it because they had a concussion, and there's risk for any loss of consciousness, you're not putting a tooth back in their mouth because of risk for them losing consciousness and then aspirating it. Okay. If you go and you implant it within 30 minutes, you have a pretty high success rate. If you send them to the ER with the tooth and it doesn't get re-implanted for more than 2 hours, it's a 5% success rate. So that's not great. Milk is not a bad solution to transport stuff in if you don't have saline or sterile water. So milk is very tooth friendly. A lot of times you can transport these. There's a little thing called Save a Tooth, which athletic trainers have. So if you have somebody who is not conscious, or you have concern about them losing consciousness, then you're stuck just transporting the tooth with them and giving the ER a heads up and having them call dental. If somebody is able to be transported, and you can either send the tooth in the socket and you can have them hold it. I usually put a saline soaked gauze on top of it and have them hold it in place. Or if you can't have them hold it in place and you don't have a Save a Tooth, then putting in a saline soaked gauze is your next best thing. These people need splinted right away. They are all going to need root canals, because if you pop the tooth out, you've damaged the root. And then once dental gives them clearance, you can send them back to play. But a lot of times if they have the dental trauma, they need some time off. Tooth fractures, when you have a partial break in the tooth.
I had a quick question.
Sorry, my volume's not great.
Oh, you're fine. I was just curious with referrals, like if they were to see a dentist versus like OMFS, like how would you decide, or do you just leave it up to dentistry to decide where they should go?
Yeah, it's up to dentist. OMFS always gets tied in if they're in the ER in most cases. But dental will get tied into, like the kid who we saw the other day was seen by both OMFS and dental. And I think a lot of times OMFS will send a lot of the basic tooth stuff directly to dental to take care of. OMFS will get involved more with facial fractures. But you're never wrong tying them in, especially in the ER setting. All right.
Another quick question, Doc.
Yeah.
The top row teeth, obviously, like you try to implant it in, and then you kind of just have them like hold it there until they get to the ER.
Yeah, your volume's not great. Can you say it again?
Sorry, is this better?
Yeah, a little bit.
Okay. If the top tooth is out, you definitely try to put it back up there, but it's probably not going to stay there. So you just have them hold it until they get to the ER, or
Yeah, you're totally breaking up. All I hear is you say top tooth. You want to put it in the chat? Yeah. Whenever, if you're putting a tooth back in, I essentially, if the athlete's conscious, no concerns, you put the tooth back in. I usually give them a saline soaked gauze, and then I just have them hold it in place. So, and they have to go right away to the ER, and again, call ahead so you get dental involvement. So tooth fracture wise, there's really two types of fractures. One's a simple, no pulp involvement. The other is a complex with pulp involvement. Again, this is high velocity force, no mouth guard. If the pulp is involved, it's painful. And a lot of times you'll see visible bleeding. So visible bleeding lets you know that you're dealing with more of a pulp injury. If there's a fragment, you do nothing for it. That's just follow up with dentist. If they're having significant pain and it's tolerable, then follow up with a dentist when you can. If you're having significant pain that's not tolerable because you're having that pulp involvement, then a lot of times you can send to the ER to get dental involved right away. Return to play is variable. Most of the time, if it's a picture like this, they can go back in right away. If you have pulp involvement and they're uncomfortable, I usually hold them out. And then I think we're finishing up here, jaw issues. So whenever there's a trauma to the jaw, you're going to want to assess and check for that TMJ or potentially a fracture. So you can have either a unilateral or a bilateral TMJ dislocation. Whenever you have direct trauma and the jaw is open is what puts you at risk. If the teeth are clenched and the jaw's shut, that TMJ is usually not going anywhere. So the things that put people at risk for having a TMJ dislocation would be real shallow fossa, underdeveloped condyles, that ligamentous laxity issue with Marfan's, Ehlers-Danlos, or prior dislocation. Most of the time with the direct blow, they're going to have pain near the TMJ. They're going to feel like their teeth aren't closing properly. They're going to have potentially an underbite if they're out bilaterally, and sometimes they'll have difficulty speaking. If it's unilateral, it may not be as obvious. So you can do a plain radiograph. This is a good example. So here you see the condyle, here you see the fossa. And if you just slip right out to the front, it explains why you're going to have that underbite because that jaw is just sliding forward. If you have this issue happen bilaterally, you can try and relocate them on the sidelines. I've never seen this before. I have had a couple kids come in for concussion evaluations, and they are really coming in with facial trauma and more of like a TMJ subluxation, but I've never seen a dislocation before. But you're essentially gloving your hands. You're sticking both thumbs way back into the back of the mouth. You're trying to push down as much as possible on that inferior mandible with both fingers, and then just trying to do that downward pressure because you're essentially trying to push down way back here and try and get that condyle to pop right back in. So just really trying to pop it back in. I tell people you can attempt once. If you can't get it in, send this person to the ER. And then the other thing that's important is if you do relocate somebody, this person really needs to see OMFS or a TMJ specialist as soon as possible. Because if they're getting relocated, they're going to have a high risk of an iatrogenic fracture or needing something wired shut. So if you relocate somebody, I personally would still send them to the ER. Mandible fractures are not uncommon. You can see them from lots of different injuries, including hockey, where your facial protection's only up top a lot of times. You're really looking for anybody complaining about jaw pain, malposition of the teeth, trouble biting down, numbness in the lower lip. You're going to want to make sure you're checking the airway, ruling out any concussion. It's a sign of a high force injury. So looking for basilar skull fracture, vertebral artery dissection. You can do plain radiographs with a panoramic view. Again, this is going to be something that's happening in the ER in most cases, and they're going to have OMFS involved. A lot of times they need wired shut with a soft diet. I think that's it. Yeah, that's actually it. We made it through pretty good, about an hour. So a lot of good kind of practical sideline stuff. Any questions at all? We plow through. All right, I'll let you guys go do clinic. And then I'll be sending out next Friday, you guys are gone, right? Okay, so next Friday, you guys are gone. I will make sure that we get a schedule out to you after that because I'm just finishing it up. So I usually release it in month intervals. Okay. All right, have a good one. Bye.
You too.
Thanks, bye.
Yeah. No, I'm lecturing. What's up?